Hello, and welcome to NCG's webinar, Meaningful Use Stage 2, What Does It Mean? As your practice advocates, we are helping to redefine the way healthcare is delivered. Since 1979, our mission has been to provide software, strategy, consulting, and technologies that help create next-generation RCM solutions. We make it possible for healthcare organizations throughout the country to reap the benefits of our entire suite of tools, designed to maximize practice management benefits and overall cash flow. NCG Medical, in a little over 3 decades, has affected over 2,000 healthcare facilities nationwide with services ranging from practice mergers and acquisitions, strategic planning, financial advisory and compliance, to operation improvements, transaction facilitation, and clinical and technology integration. But the most important message here is not longevity, it is dependability. Improving the way healthcare is delivered is not just a tagline, it's what we do, one client at a time. Before we get started today, I'd like to introduce myself. My name is Heather Miller, and I've been working in the healthcare industry for over 20 years, and I've assisted hundreds of practices with diagnosing and solving practice problems. These issues have ranged from revenue cycle management, Medicare and Medicaid compliance, practice workflow analysis, electronic health records, and strategic business planning. And I'm excited today to share with you NCG's Meaningful Use Stage 2, What Does It Mean to Me? So on August 23rd of 2012, CMS announced a final rule to govern Stage 2 of the Medicare and Medicaid EHR incentive program. The rule specifies the Stage 2 criteria that eligible professionals must meet in order to continue to participate in the EHR incentive program. The final rule for Meaningful Use Stage 2 intends to increase health information exchange between providers and promote patient engagement by giving patients secure online access to their health information. During this presentation, we are going to first discuss what Stage 2 means to you as an eligible professional, determine your meaningful use path, and then we'll discuss the changes from Stage 1 to Stage 2 meaningful use and take a quick look at the new core and menu objectives. We then will dig a little deeper into Stage 2 and discuss the changes for clinical quality measures, and we will end the presentation overviewing the incentive and payment adjustment schedules. So let's get started. Basically, Stage 2 means to all of us that it's just not enough anymore to own a certified EHR. Providers have to demonstrate to CMS that they are using their EHRs in a way that can positively impact the care of patients. So what this really means to you is that there is new criteria. Starting in 2014, providers participating in the EHR incentive program who have met Stage 1 for 2 or 3 years will need to meet the new Meaningful Use Stage 2 criteria. Second, a focus on improving patient care. Stage 2 includes new objectives to improve patient care through better clinical decision support, care coordination, and patient engagement. And lastly, a focus on saving money, time, and lives. With Stage 2, EHRs will save our healthcare system money, save doctors and hospital time, which in end save lives. So what is your MU path? This is a timeline of participation and payments by stage of meaningful use for Medicare-eligible professionals. EPs will follow their own path based on what year they began their first attestation for meaningful use. For those EPs that first attested in 2011, they have reported for 3 years Stage 1, and 2014 will be their first attesting for Stage 2 requirements. As you can see on the table, they are still eligible for a $4,000 incentive payment and will also avoid the new 1% penalty that is being assessed beginning this 2014 reporting year. For Medicaid-eligible professionals, there's a very different participation and payment schedule than Medicare. Eligible professionals always begin participating by demonstrating in their first year AIU, or Adopt, Implement, and Upgrade. After that, each year they will be responsible for demonstrating meaningful use under Stage 1 requirements. There are currently no payment adjustments in the Medicaid EHR incentive program for not participating. The last year a Medicaid-eligible professional can participate is 2016, and participation does not need to be during consecutive years. So let's talk about 2 key changes that CMS and the Office of the National Coordinator have established in the Stage 2 requirements. These new standards and certification criteria will take effect in 2014. Even if you already have a certified EHR, you will have to adopt or upgrade to the new certification in order to participate in the EHR incentive program beginning in 2014. EHR technology that is certified to the 2014 standards and certification criteria will allow providers to meet both Stage 1 and Stage 2 MU requirements. Because all providers must make this upgrade or adopt a newly certified EHR in 2014, all providers, regardless of their stage of meaningful use, are only required to demonstrate meaningful use for a 3-month or 90-day EHR reporting period. Medicare-eligible professionals beyond their first year of meaningful use must select a 3-month reporting period fixed to the quarter of the calendar year for EPs. Providers then must attest to these reporting periods no later than February 28th of 2015. Medicare-eligible professionals in their first year of meaningful use, though, may select any 90-day reporting period. And a Medicaid-eligible professional can also select any 90-day reporting period that falls within the 2014 calendar year. So beyond reporting periods and EHR certification requirements, there are 3 distinctive trends differentiating Stage 2 from Stage 1 requirements. First obvious difference is the change of the number of objectives, core and menu. Some of the Stage 1 objectives are eliminated in Stage 2, while other previously published objectives are combined, and Stage 2 adds some new objectives as well. In Stage 1, EPs were required to meet 15 core objectives and 5 of 10 menu. Stage 2 requires the EPs to meet 17 core objectives and 3 of 6 menu objectives. Specialists can still apply for exemptions if they have special circumstances, but they will no longer be able to count an exemption as one of their required menu objectives. Furthermore, most of the threshold percentages of those objectives that started in Stage 1 and continue in Stage 2 will just be increased. Overall, you will be required to meet about the same number of objectives as you did in Stage 1, but more effort will be required to pass each objective requirement. Health IT holds major promise for patients as well as healthcare providers. The government has raised awareness of how patients can use Health IT, but they are putting some of that pressure on the doctors now. Beginning in Stage 2, EPs must provide over half of their patients with the ability to view their health information electronically. That in and of itself isn't too difficult, but the real tricky part comes with this requirement. 5% of patients must view, download, or electronically transmit their electronic medical records, and then 5% must also send secure messages back to the EP. Because of the increased expectations for patient engagement in Stage 2, a patient portal is essential in meeting the new objectives. Most practices will have to do a better job of educating their parents that a portal is available and what they can do with it. This particular focus has caused many questions and concerns by the EPs as to why is it their responsibility to ensure that patients do these 2 things, and how are they going to ensure this happens. Possible suggestions have been setting up kiosks in your lobby that allow the patients to sign into their portals, access their information, and send messages. Even with these objections, CMS is sticking to their story and in stressing the importance of patient engagement in their health care. Another important focus for Stage 2 is electronic information exchange and/or interoperability. The ability to exchange health information across state and vendor lines is a key element of making healthcare better for patients. Stage 1 made very little progress in this area, so interoperability is a large focus in Stage 2. While most of the changes will happen on the EHR's vendor's end, just know that you will be required to share at least one summary of care record with a provider who uses a different EHR vendor. That requirement will increase in Stage 3, so your practice and your patients will be better off if you get in the habit of sharing as many records electronically as you can. Again, another objective that's caused some backlash from the EPs in their ability to control this interoperability of their software, and one provider specifically if they have different systems. So let's get into the requirements. What are Stage 2 requirements? Like we said, there's 17 core objectives, there's 6 menu objectives, and many of these objectives in Stage 2 are going to be familiar to you. Some objectives that were in the menu set in Stage 1 have moved to the core set in Stage 2 and are now required for all providers. Some objectives that were in the core set in Stage 1 now have higher thresholds that you must achieve in order to successfully demonstrate use of the EHR in Stage 2. And then, of course, there's also some new Stage 2 core menu objectives. The next few slides, we're going to take a quick look at each of the core and menu measures so that you can see at a glance what the objective requires, what does it mean to you, and if there are any exclusions. Keep in mind this is only going to be a quick guide, and there are many details about meeting these objectives that cannot be addressed here. So let's start with number 1, CPOE, or Computerized Provider Order Entry. Again, a core menu from last year, but that now includes for at least 60% of your medication orders. You now must do 30% of your lab orders and 30% of your radiology orders. You or a licensed staff person will have to use your EHR's CPOE module to enter these orders. The only exclusion being is if that you write fewer than 100 medications for radiology or lab orders during the reporting period. Number 2, e-prescribing, a core menu from last year that now has increased from 40% to 50% of all of your prescriptions you write have to be compared to at least one drug formulary and sent electronically, not by phone or fax, using your certified EHR. Again, only exclusion being is if you write less than 100 prescriptions during the reporting period. Record demographics, a core from stage 1 that is now still in stage 2, but has been increased from 50% to 80% of your patients. You have to record in your certified EHR their preferred language, their gender, their race, their ethnicity, and date of birth. Again, no exclusions for this objective. Vital signs, a core objective from last year, or stage 1, that is still a core objective in stage 2, increased to 80% of your patients who are age 3 and older, and you have to record blood pressure. For more than 80% of your patients of any age, you have to record height and weight. The only exclusion would be is that recording all 3 vital signs if you don't believe these vital signs are relevant to your scope. And the new to stage 2 is you can also be excluded from recording just blood pressure if you don't believe blood pressure is relevant, or just height and weight if you don't believe they are relevant. Moving on to number 5, smoking status, again a core measure from stage 1, moving over to stage 2 with an increase in threshold to 80% of all patients you see who are age 13 or older, you must record their smoking status. Number 6 are interventions or clinical decision support, again a measure that was in stage 1 that is now in stage 2 and has increased from 1 clinical decision support rule to 5 clinical decision support rules that you're in your certified EHR. The ones implemented should be related to 4 or more clinical quality measures you report on. Certified EHRs will come with the ability to automatically check for potentially adverse drug and drug interallergy interactions, thus meeting that requirement. There are no exclusions for this objective, and the only other exclusion for the prescriptions is if you write less than 100 during the reporting period. Number 7 is incorporating clinical lab test results. This is a menu set item in stage 1 and has now become a core objective in stage 2, and results from over 55% of labs ordered during the reporting period are recorded as structured data in your EHR. You can be excluded if you did not order any labs during the reporting period. Number 8, a patient list. Again, a core or a menu measure in stage 1 has now moved to a core measure in stage 2 where you can decide what condition is clinically relevant or useful to your patients and then generate a report from your certified EHR of the patients with that condition. There are no exclusions for this measure. Number 9, preventative reminders. A menu measure in stage 1 now becomes a core measure in stage 2, and this measure has changed slightly. Now you can limit patients who receive a reminder to those with whom you have more frequent contact. Over 10% of patients with 2 or more office visits within the last 24 months. The reminder should, though, be sent via the patient's preference of the methods available. Only exclusion being is if you've had no office visits in the 24 months before the reporting period. Number 10, patient access. A menu item in stage 1 now becomes a core measure in stage 2. Not only do you have to provide online access to health information for over half of your patients, you must also make sure that 5% of your patients actually access this online information you have made available. Only exclusions being is if that you did not order or create the file beyond the patient name or provider name, and also if your practice is in an area with low broadband availability. Providing clinic summaries for your patients, a core measure in stage 1 that is now still a core measure, but has increased to or actually decreased the days that you have to get this. So for more than half of your office visits, patients will receive a clinical summary within 1 day of the visit. instead of the 3-day requirement from stage 1. Only way to exclude is if you did not conduct any office visits during the reporting period. Educational resources, number 12. A menu item in stage 1 now becomes a core item in stage 2 that for over 10% of your patients, you should use your certified EHR's ability to recommend educational resources. Your EHR is certified with the ability to make these recommendations based on the patient's specific variables, such as a specific chronic condition. Number 13, secure messaging, a new core item for stage 2 in which your certified EHR will contain the capability to send secure messages between you and your patients. In order to meet this objective, you have to make sure that more than 5% of your patients actually use this capability by sending you a secure message. You can be excluded on the idea that you had no office visits, or again, that your practice is in an area with low broadband availability. Number 14, medication reconciliation. Menu item from stage 1 now becomes core in stage 2 that for over half the patients who see you after receiving care from another provider, you should update their medication information by comparing that medical record to either an external list obtained by the patient, the hospital, or the other provider. Only way to be excluded is if you don't see any patients that have received care from another provider. Number 15, provide a summary care record for each transition of care or referral. Again, another objective that we saw last year, and in this year, the measure says that you need to provide a summary of care recording for more than 50% of the transitions, and then that summary of care record for more than 10% of those transactions needs to be sent electronically through your certified EHR technology. And lastly, that one of those needs to have a different EHR vendor than you are currently using. Only exceptions being would be if you transferred less than 100 patients during that 90-day period. Immunization registries. A menu item from last year becomes a core item for this year, in which your EHR will come equipped with the ability to electronically send immunization data. Stage 1, you tested this ability, and now in stage 2, you must successfully submit this information. Only exclusions being is that you don't administer immunizations, or that your jurisdiction where you are located, your immunization registry is not capable of accepting this information. So let's look at our 6 core measures quickly. Again, you're going to choose 3 of these. Let's start. Oh, wait, I forgot one real quick, the most important, number 17, our security analysis. This is where you are going to meet the same HIPAA requirements for protecting patient information in your EHR as you did in stage 1. And to do this, you're going to have to conduct a security review of your system and correct any problems that could make patient information vulnerable. Again, no exclusions to this measure. So now moving on to menu objectives, and again, choosing 3 of these will get you to your 20 total. Imaging results that are accessed through your EHR. New to stage 2 is that for over 10% of all your tests that yield an image, the test results must be accessible through your EHR. They can either be stored or they can have a direct link from the actual lab. You can be excluded if you order less than 100 images during the reporting period. Recording patient family history. New to stage 2, this menu measure says you must record family history for over 20% of your patients. The family health history must include 1 or more first-degree relatives. Syndromatic surveillance is our next one, and that is basically the successful submission of syndromatic surveillance data. Again, your EHR will come equipped with the ability to do this. And as we said in stage 1, we tested this ability if you chose this as a menu item, and now you just have to prove this can happen. Again, if you are not a provider who collects this information, you could exclude, or again, if there is not a public health agency that's in your area that is capable of receiving this information. Same is going to be the case for the submission of cancer to a cancer registry. Again, your EHR will become equipped with the ability to do it. You could exclude if you do not directly treat cancer or you don't have an agency that's available to submit to. We're going to see the same thing with specialized registries. Again, submitting specific information based on your specialty, and exclusions being based upon, are there one available in your area, and can or can they not receive the information. And number 6, our last objective we'll review today, is enter an electronic progress note for more than 30% of your unique patients. This is specific to, basically, it must be a text searchable. Non-searchable notes do not qualify, but this does not mean that all the content has to be character testing. So there's no exclusions. Everyone who selects this measure must meet the objective. So the only important note is while there are exclusions here for these menu objectives, you cannot select a menu objective and claim the exclusion if there are other menu objectives that you could report on. It's rare but possible that none of the menu objectives are applicable to your scope of practice, and if that's the case for you, and you qualify for all of the exclusions for each of the menu objectives, then you can select 3 menu objectives and claim the exclusion for each. However, if you do not qualify for all the exclusions to the menu objectives, you must go back and select ones that you can report on. So since we've only had a chance to present the basics, I encourage you to explore the Stage 2 Meaningful Use specification sheets that CMS provides for you. You can find them on the web link above. These are excellent resources that give in-depth information on each of the objectives, including how to calculate numerators and denominators, definitions of important terms, and additional information about achieving the objectives. 2014 Meaningful Use also brought some stages to Stage 1 requirements for those EPs who will be attesting for the first time. Quickly looking at these, we do have an alternative CPO measure, which gives an optional denominator. Vital signs, now you have the option to exclude blood pressure and be separated from height, weight. You have the testing of HIE, which actually was a measure that was removed and no longer needs to be reported on. And the biggest change being an electronic copy and online access of their health information. EPs in Stage 1 must provide patients with the ability to view online, download, and transmit health information. But they do not have the requirement in Stage 1 where 5% of patients access like their peers do in Stage 2 Meaningful Use. Now, let's look at clinical quality measures with the 2014 Stage 2 requirements. Even though reporting CQMs are no longer a core objective of the EHR incentive program, all providers are required to report on CQMs in order to demonstrate meaningful use. The reporting of clinical quality measures has changed for all providers. EHR technology that has been certified in the 2014 standards now contains new CQM criteria, and eligible professionals will report using the new criteria regardless of whether they are participating in Stage 1 or Stage 2. There is an effort being made to begin streamlining the multiple quality programs EPs are accountable to report on. A first attempt and option being available to EPs in 2014. Please note that your attestation for the Medicare EHR incentive program is not complete until you submit clinical quality measure data. So your EHR incentive payment will be held until your electronic submission is processed. New to 2014, eligible professionals must now select and report on 9 of a possible list of 44 approved CQMs for the EHR incentive program. There are also new requirements in 2014 that the quality measures selected must cover at least 3 of the 6 available national quality strategy domains, which represents the Department of Health and Human Services NQS priorities for healthcare quality improvement. The 6 domains are listed above: patient and family engagement, patient safety, care coordination, population and public health, efficient use of healthcare resources, and clinical processes and effectiveness. You can find a complete list of these CQMs for the EHR incentive program and their associated national quality strategy domain on the webpage provided above. CMS has also published a recommended core set of CQMs for eligible professionals that focus on the high priority health conditions and best practices for care delivery. You have 9 CQMs for adult population and then 9 CQMs for the pediatric population. These recommended core sets focus on conditions that contribute to the morbidity and mortality of most Medicare and Medicaid beneficiaries, and also focus on areas that represent national public health priorities or disproportionately drive healthcare costs. And one of these sets is applicable to your patient population. CMS recommends choosing these 9 CQMs. So like we said, in an effort to begin streamlining quality reporting programs, as we discussed, In 2014, Medicare EPs now do have two options in how they can submit clinical quality measures. First, they have the option of submitting 3 months of clinical quality data online through your registry and attestation system, just as you've done it in previous requirements under Stage 1. New this year, you could have the option to submit a full year of data electronically using a QRDA, or in other words, an HL7 format, to receive credit for both the EHR incentive program and the physician quality reporting system. Providers who choose to submit electronically will submit their CQM data as an electronic file between January and February of 2015. EPs will not qualify for an incentive payment from the Meaningful Use program until they have submitted these CQMs. Those who choose to submit their CQMs electronically to receive credit for both programs will not receive their payment prior to 2015. So for more information on electronic submission of CQM, you can visit CMS's PQR website for more details. So as a part of the Recovery and Reinvestment Act of 2009, or ARA, Congress did mandate payment adjustments to be applied to Medicare EPs who are not meaningful users of their certified EHR technology. These payment adjustments will be applied beginning on January 1st, 2015 for Medicare eligible professionals. Medicaid eligible professionals who can only participate in the Medicaid EHR incentive program and do not bill Medicare are not subject to these payment adjustments. EPs who can participate in either Medicare or Medicare will be subject to payment adjustments unless they are meaningful users under 1. Congress mandated that an EP must be a meaningful user in order to avoid the payment adjustments. Therefore, receiving the Medicaid Adopt, Implement, or Upgrade would not exempt them from any payment adjustments. So payment adjustments for EPs that reported on a full year of EHR are based on a reporting period 2 years prior. The length of the reporting period is going to depend upon the first year participation. This chart represents an EP that reported for a full year of MU in 2012 and 2013. EPs who first demonstrated meaningful use in 2011 and 2012, they had to do a full year in 2014 to avoid that payment adjustment in 2015. They must continue to demonstrate meaningful use every year to avoid these payment adjustments in subsequent years. The table below illustrates the timeline to avoid payment adjustments for eligible professionals who demonstrate meaningful use for the full year. For those EPs that started MU in 2013 and 2014, we're only required to report for 90-day reporting periods and have different deadlines to avoid that 1% payment adjustment, and have a shorter time period between the reporting period and payment adjustment year. Eligible professionals may be exempt from payment adjustments if they can show that demonstrating meaningful use would have resulted in a significant hardship. To be considered for an exception, an eligible professional must complete a hardship exception application along with proof of the hardship. If approved, the hardship exemption is valid for 1 payment year only. A new application will need to be submitted if the hardship continues for the following payment year. In no case may a provider be granted an exception for more than 5 years. There are 5 different reasons that a EP can submit for these exceptions. Number 1 being infrastructure, where EPs must demonstrate that they are in an area without sufficient internet access or face insurmountable barriers to obtain that infrastructure. Number 2, is they're a newly practicing EP who would not have had time to become a meaningful user. They can apply for a 2-year limited exception to the payment adjustments. Number 3 is your unforeseen circumstances. Examples could be a natural disaster or other unforeseeable barrier. New to 2014 can be your EHR vendor certification issues and delays that are beyond your control. Number 4 is an EP that can demonstrate they have lack of face-to-face or follow-up with their patients. And number 5, an EP who practices at multiple locations can demonstrate that they have a lack of control over the availability of their certified EHR for more than 50% of their encounters. To avoid these penalties in 2015 for compliance in 2013, there is a deadline of July 1st, which is very close to 2014, to avoid that penalty. Deadlines moving forward for the following years will always be a deadline of July for the previous year compliance to avoid that next coming penalty. Eligible professionals can also use this new hardship exemption tool to determine if they will avoid the upcoming 2015 and 2016 payment adjustments by demonstrating meaningful use, or if you should apply for the hardship. The link above will take you directly to this cool new hardship exception tool. The best resources for you if you have further questions regarding MU Stage 2 is CMS's webpage, specifically discussing Stage 2. This link will provide you not only links to the Federal Register, it also breaks down a lot of the information into tip sheets. Listed here is a sample of what type of tip sheets you could find there, and they've also added a Stage 2 meaningful use attestation calculator for you to confirm if you have met Stage 2 requirements. So again, if you have any further questions regarding Stage 2 or if you'd like further assistance from NCG Medical, you can contact us at 1-800-330-1906. You can also email us at solutions@ncgmedical.com. We'd love for you to visit our website at www.ncgmedical.com, or you can follow us on Twitter, join us on LinkedIn, become our friend on Facebook, where we do provide lots of up-to-date healthcare industry news, as well as new technological solutions that could assist you with your day-to-day. Thank you again for attending our NCG Medical webinar on meaningful use, Stage 2, what it means to you.